So this is I have a new appreciation of what I like to call the collateral damage of treatment. And so I want to focus a little bit on that and what is wrong with the status quo. And to me, the status quo really is, first of all, as Sylvia so well pointed out, the overdiagnosis, where the goal is finding the tumor, every tumor. It's sort of like TSA screening, you know. We're going to find, and we do it like TSA screening. We overscreen, and to find everybody who might, you know, have 7 ounces of gel in their backpack or their bag, and we really don't focus in, and so we really trouble, you know, and overdiagnose people that way. And really, when you talk to doctors, unfortunately, that's how they focus. If you talk to radiologists, their goal is to find things, and they feel successful if they find them. And they don't think any further of that. Is it relevant? Do we care? Is it ever going to do anything? It's just, let's find it. Then there's overtreatment, which many of you have heard me say over the years, slash burn and poison, and is still slash burn and poison with surgery, radiation, and chemo. And we, as Sylvia again said, overtreat people because we don't know which people to treat. We have to treat everybody, and that has the collateral damage, or the true cost, I think, of breast cancer. And then the recurrences are too little too late. By the time it comes back again, you know, we don't really have enough, and we're probably not at the right time to do it. So it's not a very pretty picture. 29% in the chart, and in the papers I was looking at, about 29% of cancers diagnosed in screening would not kill you if not picked up on screening. And again, Sylvia went over some of that. 20 to 30% of DCIS will go on to become invasive if you don't treat it. That means 70% would never do anything. And yet we treat 100% as if it's going to do something. And LCIS is also about 1% per year, so a maximum of about 30% of LCIS will go on to become invasive. So that means we're treating 70% of the in situ cancers that really don't need to be treated. And again, that another 30% of the invasive cancers we're treating that probably don't need to be treated. So what is you know, our current take on this is really that we need to overtreat and overtest because we're Americans and more is always better. If a little is good, more must be better. So we do MRIs. There's no data to show that adding MRIs really is going to change very much in terms of the breast. We do PET scans, we do CTs, we look at markers, we're looking, but we treat it all equally equally dangerous. So we're again focusing on finding, but not on interpreting what we're finding and how we should deal with it. And then, you know, treatment is surgery, radiation, chemo, hormones, targeted treatment. We never subtract. We always just add something on top. So it's surgery plus radiation, it's chemo plus hormones, and then the targeted therapy plus the chemo. And we don't test whether you could do one without the other very often. I mean, some of the tests now, some of the discriminating things like Oncotype DX will help sort out who really maybe doesn't need chemo. But the American way is, let's give everybody everything. And I don't think it's malicious. I really don't think physicians are sitting there saying, you know, how can I really torture people? But I think you're in the trenches and you have one tool and that's what you do. Most don't sit and think over the bigger picture. So if you're a radiologist, you've got your radiology tools and you just do all the ones you got and see what you can do. And if you're a surgeon, you cut. And if you're a radiation therapist, you radiate. That's what we're taught to do. That's the tool we have and the instrument we have. And there isn't anybody looking at the bigger picture, and there's no voice of the public or the patient in this. and what they want. And of course, when you're diagnosed, as I can well testify, you're scared to death and you just do whatever without very uncritically. So we really need to have a time not with we can't depend on the patient and we can't depend on the doctors to be the ones to critically look at this. And we have to be the ones that do that. This is a chart of the use of aromatase inhibitors, just to show that how many people stop using aromatase inhibitors, and the red are the people who have stopped using it. So you start out with the yellow and the less. The far chart is all patients, and then tamoxifen only, and then the AIs, and you can see that electronic medical records doesn't tell this story, because the electronic medical records just tell whether the doctor wrote a prescription. It doesn't tell whether you took it. And in fact, if people aren't taking the drugs, then we need to think about this differently, and there must be a reason. And the reason is the collateral damage. And I think we don't talk about that enough. As Sylvia pointed out in that metastatic disease Bolero trial, the side effects are really downplayed. But the side effects can really have a significant change on the quality of your life. And the side effects come from every single element of treatment. And some of them there are statistics about. A lot of them there really aren't statistics about. So with surgery, we all know about lymphedema. It's about 20%. And with sentinel node, it's less, but not a lot less. And there was an interesting recent study that just came out within the last month that there may be a gene that'll predict who's going to get lymphedema. And I always wondered about this, that it may just be that some people have less lymph channels to start with. So if you mess with them with surgery, you're more likely to provoke lymphedema as opposed to other people, because it never seemed to correlate too well with the amount of surgery that we were doing. And all of this stuff about don't get your blood pressure taken and your blood taken on that side, we just made that up. We really did. This is another lesson that I've learned recently, but not that lesson, but the lesson that doctors just make things up. That because what it was, nobody knew. You'd say, well, why did I get this? Or what can I do to prevent it? And the doctors would sit around and they'd say, well, I saw a woman who had lymphedema right after she was in an airplane. I think we should tell people not to take airplanes. And somebody else would say, oh, I saw somebody who had their blood pressure taken. Let's tell them not to do their blood. There's no studies of this. There's no studies. No studies at all. I was told after the transplant not to get in the sun, and I was religiously avoiding the sun. And then I started to look it up. There were no studies. It was just like lymphedema and blood pressure. I said, forget this. They were just making it up. So decreased arm mobility. Interestingly, they actually studied with tests how much arm mobility people had. And there was a 70% decrease in arm mobility at 5 years after a complete axillary node dissection and 40% after sentinel node. So that's significant, not having full arm mobility. Pain from the surgery, persistent pain, neurologic pain, the numbness in your arm, the phantom breast symptoms some people have, the neuropathy can be significant, and the question of still having a recurrence. So significant collateral damage from the surgery. And that's not even talking about the cosmetics and all of that. And then radiation, muscle atrophy, skin changes, heart disease, second cancers, lung and sarcomas. We lost Carolina to really the side effects of her radiation. We've had enough losses in this group from the collateral damage. And it's not everybody, and I purposely, and they're not with all kinds of radiation, and you can do it a different way and all of this, but in general, I'm talking, these things all have these significant side effects. Chemotherapy, peripheral neuropathy, particularly with the taxanes, fatigue, which in one study lasts at least 10 years, and about 20% of people just doesn't go away. They're finding maybe it might affect your immune system and cytokines. The chemo brain, I know deep in my brain how that works right now, but But that's real and persists in many people. The heart disease from some of the chemotherapy drugs, the second cancers, there's with some of the anthracyclines, there's a doubling of leukemia caused by the chemotherapy you had for the breast cancer, or MDS, which is the DCIS of leukemia. What Robin Roberts has is secondary MDS from the chemotherapy that she had from her original breast cancer. It's not common, but it does happen, and it's real. Infertility is a big problem. Hormone therapy, hot flashes, decreased libido, arthralgias. 57% of women have significant joint problems with the AIs. Fractures, cataracts, second cancers, endometrial cancers. This is not a free lunch. And the results are not terrific. Now, this is an interesting chart because this is 20 years survival. So it's before Herceptin, and it's different subtypes. But what it shows you, it's from Kaiser, so they were all treated the same, and they're pretty much the same women, that the one that's the straight solid line going across, that's actually the triple negatives. So the triple negatives, you either go soon or you're fine. You know, they're once you get to about 7 years, you really, if you made it, you're probably pretty good. Whereas the one that keeps continuing to go down on the top, that's the ER positives. So the ER positives, not so much, you know, you do pretty well in the beginning, but you continue to get recurrences way out at 16, 18, 22 years. The other two lower ones are the HER2 positives before Herceptin, so it's harder to judge those. But I think it's interesting that if you look out at 20 years, the triple negatives are better than the ER positives. So this is a long-term perspective, and these side effects and things are long-term. So what's the answer? Prevention, I think. I think we really have to not get it in the first place. It's not getting another drug with a whole other set of side effects for another extra month of life. It's really not getting it. And you've heard me say before, you know, cancer of the cervix, we went from doing hysterectomies but for an abnormal pap smear to having a vaccine. And that's really what's in my brain. So one question for, you know, what are the things you can look at for prevention? One is, could it be infectious? Well, the bugs in the breast theory. My bugs in the breast. People, we've always thought that the breast was sterile, but any organ that gets sucked on by lovers and babies and everybody else probably isn't sterile. It's probably got bugs. And we're looking at it at the Dr. Susan Love Research Foundation, as are many others. Could it be a virus? Could it be a and we have a lot better ways to look at these things now than we did in the past. An immune vaccine, the Artemis Project is also looking into bugs in the breast and the possibility of, is there a way to have an immune vaccine? One of the interesting things about treatment for leukemia is that if you have a transplant, is that partly the transplant itself is a treatment because it's like a vaccine. If any leukemia cells pop up later on, they're not recognized by your new immune system. They're recognized as foreign by your new immune system. So your transplant kills them off. So having an immune kind of vaccine that could take care of any cells that come up would be really good. Understanding the normal breast, how it works, and really the beginnings of breast cancer. I worry about the TCGA because what they called normal was right next to what they were calling abnormal, and we have no idea. Does the whole breast get cancer? Is it one duct? You know, how does that work? And if we're going to prevent it, we have to understand that. And then finding new clues. The Health of Women study, where we're tracking women over time and asking women what they think and what questions they want to see asked, I think is going to be really important. And then short term are things like being able to map DCIS. This is my current fixation. But the problem with DCIS is it's little microcalcifications, and is what we see on mammogram. But the microcalcifications are not the whole disease. They're just in one spot of a bigger picture. So you've got this disease that's tracking through the ducts, and you see the ducts in the middle, so tracking through one of those ducts, but you just have the calcifications at one little speck. And so we biopsy and operate on the calcifications because that's all we got as a marker. And we often miss, we have dirty margins, we don't get it all because we don't know the extent of the disease. And we end up doing mastectomies. If we had a way of visualizing, of imaging how much DCIS there was, then we could make our surgery much better. We could get it all out. Or maybe we wouldn't have to get it out. So this is an ultrasound on the far picture of a duct with just salt water in it, saline in it. And if you could do that, you could, and maybe, so we're looking at, could you use 3D ultrasound to image the extent of DCIS? I mean, if you could see those babies' noses and ears, you know, in utero, why not see DCIS in a duct? Maybe, I don't know, maybe it has to be fancier than that. Maybe you need molecular markers. But I think this would be really important. And the reason it's important in prevention is because then you could look at not treating it. Remember, 70% is not going to do anything. So what if you could do watchful waiting then? Because you could image it, and then 6 months later you could image it again and see if it was getting worse or not. Right now, we have no way of doing that. You're not going to see if you have more calcification. You know, calcifications are not going to tell you that. You could see if maybe tamoxifen would make it go away without having surgery, or Herceptin, or all kinds of things. You could test a vaccine on it. But right now, you can't do anything for DCIS because you have no way of knowing how much there is when you start. You have no before picture for the after. So if we could do that, we could maybe stop over-treating DCIS and really start to get some insight into what stops and ends this earlier stage. So I think that the vaccines are a long-term prevention, and I think this could be a really short-term project that maybe could give a more rapid way to test prevention as we go forward in the future. So, you know, the summary is the status quo is not enough. The status quo is really not great. And yes, we've made some progress in treatments, but at a big cost in collateral damage that's often underestimated by the medical profession. I said to one of my physicians, "You don't really care whether I have numb toes, do you?" And he said, "No." Well, I do, and I care that my brain doesn't work right. I mean, I'm happy to be here, but it would really be better not to have all the collateral damage. And so I think prevention is the way we have to go, and that's why really the deadline is the answer. Thank you.